So, going to the stepwise approach, the things that you will need to quickly do include making sure that you have the right patient's information, looking at the patient's or the chest x-rays image quality, describing the obvious abnormality, including localization and description. Make sure that you're saying the right side or the left side. I've seen a lot of people saying pneumothorax, but not really saying which side it was on. And describing the abnormalities on the chest x-ray in a bit more descriptive manner, like for example infiltrates, reticular pattern, a nodular pattern, or a cavitating pattern. Um, then go on and describe other structures such as airways and lung zones, look at pleural space and costophrenic angles, cardiac shadow, equipment, bones, and then look at outside the chest. Make sure that you have looked outside the chest, including subcutaneous spaces, bony shadows, as well as neck swellings, and sometimes fracture of the humerus. Sometimes that can be missed as well. Now let's go through some pathologies, and this is just a very quick description of most of the pathologies that you will come across while describing a chest x-ray. So what is atelectasis? Atelectasis occurs when there is a failure of the lung to expand completely, and that this may be caused because of a number of reasons or number of processes that can result in reduced alveolar ventilation, including blocked airways. It could be mucus plugging of small bronchi, even after general anesthesia, pneumonias, splinting from pain after surgery, or blocked airways. Um, on occasions, left lower lobe atelectasis is not an uncommon thing to see in most of the ICU patients. As far as the features of atelectasis on the chest X-ray are concerned, what you see specifically are elevation of the hemidiaphragm, a displacement of the fissure towards the atelectatic side. You will see that there will be crowding of the vasculature or splaying of the vasculature seen in the non-affected lobes due to compensatory emphysema. You could see mediastinal on occasions, on very few occasions, especially when you get collapse, you might see mediastinal shift, but not necessarily only with baseline or basal atelectasis. And sometimes you can see the Silhouettean sign, which means the lack of the crisp differentiation of the denser structures from the lighter structures. Um, Atelectasis can be bilateral basal, in which case the hemidiaphragms appear elevated, or there is poor visualizations of both hemidiaphragms. For example, in this particular X-ray, you can see that the hemidiaphragms and the cardiac shadow appears as if it is buried within the diaphragms, and the diaphragms appear to be a lot elevated than normal. And this is just basically because of bilateral basal atelectasis. And there sometimes might be infiltrate seen within the lower zones, which might indicate the presence of atelectasis. On occasions, you may also visualize that there are certain bands within the lower zones, and these are called as atelectatic bands. And as I said earlier, that you might actually visualize infiltrates rather than the bands themselves. Now, the same kind of causes which cause atelectasis, such as mucus plugging of small bronchi, themselves can eventually result in lung collapses or lobar collapse. The same kind of causes we would be able to describe in lung collapse as well, deviation. Um, and let's go through each of them first. So the right upper lobe collapse. Um, the classical findings of a right upper lobe collapse will include um, increased density in the upper medial aspect of the right hemithorax, elevation of the horizontal fissure. On most occasions, the elevation of the horizontal fissure usually results in an S-shaped appearance. Sometimes you can see a loss of the normal right medial cardiomediastinal contour. There'll be elevation of the right hilum as well as hyperinflation of the right middle and lower lobe. Like as you can see in this particular X-ray, the two arrows demonstrate the horizontal fissure which is elevated, as well as the right right main bronchus appears to be elevated as well, indicating the elevation of the right hilum. And what are the most common reasons for right upper lobe collapse and left lung collapse in intensive care? And it is endobronchial intubation, as is the case with this particular patient. As you can see, the endotracheal tube is way too far into the right main bronchus, probably actually occluding the right upper lobe bronchus, and that has resulted in significant collapse of both the left lung as well as the right upper lobe. Other causes of the lobar collapse could, as we described earlier in atelectasis, could be mucus plugging, foreign body, or aspiration, or even compression by a tumor. And sometimes you can have bronchial tumors, which might cause obstruction as well. The right upper lobe collapse, because of the classical features that it demonstrates, is quite easy to pick up on a chest X-ray. On the other hand, a right middle lobe collapse is extremely difficult to visualize, and some of the findings of a right middle lobe collapse might be very subtle, and therefore it might be very difficult for you to actually say this is a right middle lobe collapse. Normally, the findings that we commonly visualize is that the normal horizontal fissure is no longer visible. Now, on most occasions, the horizontal fissure is not very well visualized on the chest X-rays anyways, and it becomes very difficult to see this sign. There might be blurring of the right heart border, increased opacity adjacent to the right heart border, and therefore there was a loss of Selhout sign. There may be elevation of the hemidiaphragm, crowding of the right-sided ribs, as well as shift of the mediastinum to the right. Now, in this particular X-ray, you can see that the right heart border is not well visualized, as well as the right hemidiaphragm appears to be tented upwards. And there is a reduction, or there's a lack of loss of volume on the right side, and the left lung appears to be hyperinflated compared to the right. There's a triangular density just next to the right heart border, as well as the diaphragm elevation that you can clearly see on this particular X-ray. This indicates the presence of a right middle lobe collapse. Now, right lower lobe collapse, on the other hand, a complete collapse of the right lower lobe, although usually very easily seen, sometimes it can be missed if there is no significant consolidation and the film is a little bit rotated. But the classical findings that you can visualize for a right lower lobe collapse include increased opacity, which is usually triangular in shape at the medial base of the right lung. Usually it results in there is a middle aspect of the dome of the right hemidiaphragm is lost. The right hilum is usually depressed or is pulled downwards, and the descending right lower lobe pulmonary artery is also not visualized. We can see it on this particular X-ray where the patient has got a tracheostomy, a nasogastric tube, and a left side chest drain. You can see a triangular opacification, which has resulted in the lack of the proper demonstration of the hemidiaphragm, and the middle aspect of the dome of the right hemidiaphragm is completely lost. And this is classical finding of a right lower lobe collapse. The left lower lobe collapse, on the other hand, can be identified by the presence of a triangular opacity in the posterior-medial aspect of the left lung. Now, this results in a classical finding where the edge of the collapsed lung may create a double cardiac contour. As we can clearly see on this particular X-ray, there's a triangular opacity just next to the paravertebral border on the left side, and the edge of that appears as if it's creating a second border or a second cardiac contour. This will obviously result in the collapse. Because it causes collapse of the left lower lobe, it actually pulls the hilum downwards, resulting in the left depression of the left hilum. There will be also loss of the normal left hemidiaphragmatic outline, as well as the loss of the outline of the descending thoracic aorta. Now, this is not very difficult to interpret as well as comment on, and the causes would remain the same: mucus plugging, endobronchial tumors, or compression by tumors, as well as aspiration or foreign body, so on and so forth. Left lower lobe collapse can be identified by the left upper lobe collapse. On the other hand, usually results in a very thin sheet of collapsed material, and it results in this particular pattern is very difficult to interpret because as the left upper lobe collapses, it actually collapses anteriorly and forms a thin sheet of tissue opposed to the anterior chest wall, and therefore it doesn't result in the classical dense opacification but results in this hazy wheeling opacity extending out from the hilum and fading out inferiorly. It obviously results because left upper lobe is a significantly large structure anterior. It results in the shift of the mediastinum, and therefore as we can see on this particular chest x-ray, there is a shift of the mediastinum including the trachea towards the left. There is elevation of the diaphragm. The left hilum gets elevated. There's a loss of the cardiomediastinal contours. There's obliteration of the aortic arch, as well as compensatory expansion of the superior segment of the lower lobe. And all these findings are sometimes a little bit more tricky to comment on. But the one thing that you need to basically look at is if there is a shift of the mediastinal structures, then you always try to consider the possibility of left upper lobe collapse. On occasions, you may get a complete collapse of the left lung, and this may be because of a left main bronchial obstruction, either from sputum plugging or compression from tumor or tumor infiltrated the bronchus, or even endobronchial tumors. And that results in a significant shift of the mediastinum to the left side. There will be shift of the trachea towards the left side. There will be crowding of ribs, loss of the left hard border or diaphragm, and white out of the left side of the hemithorax. We can clearly see on this particular x-ray that the trachea is completely shifted towards the left. Can't really visualize the hard border at all, and it appears that the heart has been completely moved towards the left hemithorax, indicating a complete collapse of the left lung. Now, on most occasions, even if there has been a sputum plugging, for the chest x-ray to demonstrate a presence of a complete whiteout, it might take a few hours. So even if there is a complete obstruction of the bronchus, it might take a few more hours before a complete whiteout is visualized. But the important thing is that on examination, you may notice that the hemithorax is particularly not moving at all on inhalation, and you need to basically examine the patient and compare it between pneumothorax versus collapse of the left lung. X-rays, probably on occasions you may not be able to completely differentiate a complete left lung collapse quite easily. Let's have a look at this particular X-ray. On occasions, as we discussed earlier, a complete left lung collapse may also be seen because of an endobronchial intubation, like in this case where the endotracheal tube appears to be in the right main bronchus, and there is a complete opacification of the left lung, indicating a complete left lung collapse. Endobronchial intubation could present with both left lung collapse. On occasions, if the endotracheal tube is too far in, it might actually cause a right upper lobe collapse as well, resulting in this classical picture on the right side, where there is a right upper lobe collapse as well as a complete left lung collapse. And obviously this particular patient has a left-sided pneumothorax as well, which is why there is a chest drain in place.